Ladies and gentlemen, please welcome back to stage your conference chair, Anita Anand.
Thank you all very much indeed. I know how absorbing conference can be, and sometimes you sort of get pulled into this bubble, fascinating bubble it is. But I do have some sad news from outside the bubble, which I think I ought to share with you, because some of you may know Jo Cox, the MP for Batley and Spen. She was attacked a little earlier this afternoon. She was shot and stabbed. All I can tell you is that she was doing her surgery. A man attacked her. She's in a critical condition at Leeds Infirmary. So I just thought that we should start by just saying that our thoughts are with her and her family right now. Let us, though, continue with this afternoon's events. I was in a breakout session. The breakout sessions, I'm sure many of you have gone to very interesting things. But the one I was at was about Europe and what we can learn from the European example. Is that the rain? Wowzers. If it leaks, just try and bear it with forbearance. Yes, so the European example was an interesting one, because we had Denmark and Sweden, which have a completely no-blame culture. They've completely eradicated their oversight bodies, their centralised oversight bodies, like the CQC. And yet, here we are. We don't have quite as many as we used to, but it still is very much a mainstay of how we do things in our NHS here. This afternoon is going to be largely devoted to those two sides of the coin. That's how they've termed this session. It's finance, and it's also accountability and quality rather than accountability. And how do we achieve that? We have an absolutely outstanding panel this afternoon to discuss this. We've had some really stonking panels, actually, in this conference. I congratulate the organisers. They're very, very good. First of all, please welcome to the stage Anita Charlesworth, Director of Research and Economics at the Health Foundation. We have Simon Courage, Director of Product Strategy of Allocate Software, Professor Ian Cumming, Chief Executive of Health Education England, and Lord Prior of Brampton, Minister for NHS Productivity on the Department of Health's view on spending review. Please give them a very warm welcome. Do have a seat. So it would be really useful. We've had conversations this morning, and the central pivot to it all comes back to money, honey, doesn't it? So why don't we first of all welcome to the stage Anita Charlesworth, who can tell us a little bit about, give us an overview of the financial settlement, would you, Anita?
Yeah, I'm going to take that. Thank you. Hi. All right. So what I'm going to do is just use 4 slides to give a sense of the financial challenge facing us as I see it, and some of the issues that arise from that, to frame the discussion. And so this first chart here sets out what's happening over the decade that we're just over halfway through in terms of funding per person for the health service. And there are 2 things which I think you should take from this chart. The first is the line along the bottom that says 0.1%. So basically what we're trying to do in England with the NHS through this decade is spend no more per person in 2020 than we were in 2010, once you allow for a little bit of inflation. So all of the normal pressures on our system we're trying to meet by efficiency. And if we don't do that, then obviously the only alternatives to us are either to overspend and the Treasury bail us out, or to see quality and access to care fall. So, and there is really no precedent in the NHS's history, or so far as I can find in other countries, for trying to sustain such a low growth in spending for such a long period, and to bridge that gap that results through efficiency. So if it feels hard, that's because it is hard. Yeah? It's a really difficult challenge. The second thing that I think is a salutary thing about this chart is if you see where we are now in 16, 17, we are in the time of relative plenty. Yeah? And actually, we have a very short period of time to get ourselves into shape to deal with the fact that in 2018-19 and 19-20, we actually have cuts in spend per person ahead of us. So there is an absolute urgency to delivering efficiency, putting clear plans in place and achieving sustainability. The plan for what that means, of course, is £22 billion worth of efficiency savings needed over the next 5 years. The plan for those was set out recently by NHS England, and this is a chart which shows that. And I'll just highlight again a few things about that. Fundamentally, the 22 billion of efficiency comes from a mix of nearly 7 billion of national savings. That 7 billion is overwhelmingly pay restraint. And pay restraint is obviously getting harder to deliver as we hope our economy will grow and average earnings in the wider economy increases. Impossible to deliver if we can't have an engaged and well-motivated staff. So actually, one of the things I say over and over again is I think the number one financial risk to the NHS is the workforce issues, not just the numbers, although the numbers are absolutely critical, but having an engaged and motivated staff, critical to being able to deliver that pay restraint that drives a lot of these numbers. But then that leaves 15 billion to be delivered locally, and apparently we have just 1 billion in the bag at the moment. Part of that, 4.3 billion, is coming from all of the work on the demand side, principally through the Vanguard programme, new models of care, but also the Right Care programme, and nearly 9 billion from local provider productivity improvements at 2% a year. Again, you cannot do the change, profound change, that is hidden within an estimate both for provider productivity improvement or care redesign without the engagement of staff and without a stable workforce. So underpinning all of this, one of the things that I would argue is that absolute workforce issues are fundamental. They will be make or break here. Also worth bearing in mind, obviously, that 4.3 billion for activity change and the provider productivity. Both of those have at the heart of those reducing variation. Most of those savings are coming not from new innovations, but actually from the NHS being fundamentally better at taking innovations elsewhere and spreading those. We have to become really good, really quickly at spreading innovation. And this just shows that although the provider ask is less than in previous years at 2%, this is Monitor's work, NHS Improvement Now, that they did for the setting of the tariff. What they show is that what we've been delivering over recent years in terms of trend efficiency is about 1.4%. So we've got to do 50% better than we've been doing to make any of these numbers add up if quality isn't to be affected. But, as Monitor point out, there are huge potentials still from people catching up with the best. So the really big challenge for us, the really big challenge for the next couple of years, I think, is really focusing on those workforce issues and how to catch up. And I think STP programmes that don't have those two issues at their heart aren't going to be really credible answers to the next few years. Finally, then, where are we at the moment, then, in this good year, which is our precious bit of money, the front-loading of the settlement, in order to support that change programme? Well, it's amazing how quickly £5.5 billion can disappear. So we've got £5.5 billion in cash for NHS England this year, got high pressures from pay and pensions, particularly from pensions, small amount from population growth, but that provider deficit of £2.5 billion, and that's the headline deficit. Obviously, that's supported by a lot of one-off, so our run rate position is worse than that. The already committed new service improvements, even if we deliver those efficiency savings that have been expected this year, we've just got £700 million to use to get ourselves into shape. If actually the provider position slips more, then we really are in trouble. And remember, in 2018, funding growth is negative. Yeah? So it's really imperative that we focus on some of those here and now issues, workforce, not just numbers, but morale, engagement, really importantly, tackling variations, and use that tiny bit of resource wisely. Okay.
Thank you, Anita. So as you have been hearing from Anita Charlesworth, if you have these figures and you're looking at these figures, cushion of 700 million to get us into shape was the phrase that we heard. You are going to be facing some really serious workforce challenges. This time last year, you might remember, those of you who attend regularly, that we had the boy band on stage. Do you remember the boy band? We have one of the members of said boy band here still with us. We've lost two. I'll go into that in a moment. But Professor Ian Cumming is here, Chief Executive of the Health Education England. And perhaps you might be able to tell us, how is the NHS going to manage these workforce challenges?
Okay. Thanks, Anita. Let me just refer to a couple of the points that Anita made in that presentation. Workforce make or break, absolutely. We spend 70% of our total resource on the workforce. And one of the things that's been really interesting for me in the role that I fulfil in the NHS is the level of interest that we have seen over the last 12 months in workforce transformation at a much, much, much greater level than we've ever seen before. I also entirely agree that eliminating variation is critical to certainly the early stages of improving our efficiency. So the challenge that we've got over the next 4 or 5 years is really around productivity. Now, this is not productivity, beating our staff over the head, telling them they must work harder, because I know very few people in our National Health Service that aren't working really hard day in, day out. It's about how do we actually do things differently, and how do we take the best practice that already exists out there and spread it across the country and spread it quickly. Some of you may have heard in a session earlier on today that the published evidence is that it takes 15 years for a new clinical technique, a new concept, to become widespread across the NHS. I would argue we haven't got 15 years, we've got 15 months. And this is about how we get our workforce to embrace change, but more importantly, how we actually give them the time that they need to retrain, to focus on working differently. Finance directors in the room, I've said a few times that when we're in times of financial challenge, the worst thing you can do is remove the resource that you spend on educating and training your staff. This is the time when we need to put more resource into that area. We need to focus on skill mix issues. If you look at the variation that we see between wards, between departments, between different GP practices on how they are deploying the resource that we have got at the moment, it is staggering in terms of the variation. It's also staggering in terms of, if we take our allied health professional population, for example, within the scope of practice that these highly skilled, highly trained, highly competent individuals have, the restrictive scope of practice that we apply as employers when they could be doing so much more that they're already trained to do, but for reasons we're restricting. One example of that would be the work that we're doing at the moment, looking at training more endoscopists who aren't coming from a medical background, so endoscopists from a nursing and AHP background. We've been out seeking for people to train. Those units that have non-medical endoscopists are really enthusiastic and they want us to train more. Those units that don't, it's really difficult to try and actually to get them to accept that this could be a different and more efficient and more effective way of delivering care. I think the final point that find 2 points that I'd like to quickly make. The first one is about thinking about what the healthcare system is going to look like in the future, because I do not believe the way in which we deliver healthcare at the moment is sustainable or is the model that we are going to have. We are going to have much greater reliance on technology. We are going to be using iPads and other technology to access healthcare. Are we training people to work in that environment? Or are we simply expecting people to take the way in which we currently deliver healthcare and apply technology to it? And we know that that won't work. But the final point I want to just finish with is about the current workforce. So if you look at the challenge we have over the next 5 years, we have to predominantly focus on the people who are already in our employment. And we have to look after those people. Secretary of State said in his speech earlier on today that there's more than a twofold variation between NHS organisations in terms of sickness absence. There's more than a twofold variation between NHS organisations in their turnover. We've managed to attract 1,500 nurses back to work in the NHS over the last 12 months or so through a return to practice programme. Of those nurses that we've spoken to, we asked them why did they leave in the first place. I didn't get the answer I expected. I expected them to say pay, terms and conditions, morale and motivation. The number one factor they came back with why they left in the first place, was lack of flexibility in employment. They couldn't work Tuesdays, or they couldn't work weekends, or they couldn't work nights. And time after time, people have said to me that as an employer, the NHS hasn't been responsive enough to their needs, so they have left. So we have to think about the practicalities of employing people as well as how we retrain and transform the workforce.
Thank you very much, Ian. You can never have this conversation about productivity without having a conversation about technology. If you were here this morning, I started off with a headline that was in the national newspaper, The Telegraph, I think it was, saying that it was going to be technology that was going to prevent the financial meltdown of the NHS. There's some very tall expectations out there for technology. And rostering, e-rostering, I mean, that's another thing that comes out in the second breath when you talk about productivity. So Simon Courage, Director of Product Strategy of Allocate Software, I wonder if you might address that.
Thank you. Yeah, it's certainly a hot topic. And today, obviously, Jeremy Hunt himself talked about the importance of effective rostering. And the reason it is so important is because getting it right does genuinely have a major impact both on finances and on quality. And I think this diagram illustrates that, which is if this is your patient demand, if you get rostering wrong, your staffing supply doesn't match to it. And when you get it wrong in this direction, then you have financial issues, as the Carter report talked about. When you get it wrong in the other direction, then you have quality issues, as all the safe staffing reports talked about. And it's great from the panel, but also from the Secretary of State down to ward managers. Everyone agrees that this is something we need to focus on and indeed improve. But despite that consensus, again, Jeremy Hunt talked about it today, there's a number of trusts that are not doing as good enough a job here. And it's not necessarily that the tools aren't there. Most trusts have a tool in place now. It's that they're not using that tool effectively. I think this illustrates the point to a degree. And again, the Carter report talked about this variation, and we talked about it in the panel here as well. But within this variation, there's also many, many trusts who are doing an absolutely fantastic job. And we have a huge amount of success stories of where trusts have done a great job here and are both improving quality and finances. So again, as Ian was saying, I think really what we need to be doing is understanding what are these trusts doing differently and getting that best practice spread. So one of the things that these successful trusts have done differently is they've really driven engagement. And again, that engagement is two sides of the same coin. It's management engagement and it's also workforce engagement. And improving engagement can sometimes feel a little bit woolly. So I want to give you two really practical examples of simple things that can be done that really help drive an improvement. So if we start with management engagement, it's a really stunning statistic, this, but trusts that approve their rosters 4 weeks ahead of time use half the agency of those that approve late. It's really an enormous difference. And it's not actually a mystery here. The trusts that are approving ahead of time are giving the bank a much longer time to fill the gaps. But again, it's not just about the finances here, it's about the quality of the workforce as well. If you have your roster approved a week before you start, you have a really bad work-life balance. And if we talk about workforce engagement, then a big change here has been smartphones. And with our software, if you work on the bank or locum, you can see bank shifts that match you. If you only want to work a Wednesday or a night, you can see that information and you can directly book yourself into things that are interesting. And the take-up of this has been amazing. This is where people use it. Maybe they have very boring holidays, but it's really great adoption there. But again, this isn't just about making the workforce happier. This has a direct financial impact. So again, these are statistics from our user base. People that use this functionality use a lot less agency. Again, it's no real mystery why. You're providing a better service to your bank employees. And in fact, the top performing trust here, which is Cambridge University Hospitals, nearly half their bank shifts are filled this way, and they use no agency whatsoever. It's really, really impressive. And again, this is just a win-win for everyone. It's great for the employees because they're having something that they're driving. It's much easier for them to engage with what they want. It's great for the service because more bank shifts are being filled. The fill rate improves, that improves quality. Great for the trusts because they're spending less on agency. In fact, the only people it's not good for is the agencies themselves, but I don't think we're going to shed any tears there. So real win-win for everyone. So to summarise here, in terms of two sides of the same coin, there are really great examples of how effective rostering can improve both your finances and your quality, but also how getting this right improves not just the trust outcome, but it leads to a happier workforce as well, which is, as we all discussed, is really important. And engagement is absolutely fundamental to getting that right. And here are two places to start what I just talked about. Making sure your rosters are approved early and tracking that. And the areas that aren't doing that, picking them up on it. And also using that bank direct booking functionality. So my call to action to everyone in the room here is if you're not doing this stuff today, literally start next week because you can see the big impact it does have. Thanks.
Thank you very much. So we started off this Confederation conference with a conversation. It was a joint declaration from the LGA. I don't know whether you were here to hear that, Lord Prior, but it was with the LGA had come up with a joint document saying that we are signed up, and there was a great declaration of a coalition of the willing, if you like. And anecdotally, when I move among you and I speak to you, I sort of get the impression that people are on board, but they worry about the time limit. And they worry about how they're going to get there. Maybe you might speak as Minister for NHS Productivity, Lord Prior, on how you expect people to get there on time.
Well, thank you for that. I wanted to start off just by acknowledging that that over the last year we've gone through a really tough time in the NHS, but actually the underlying performance in many areas of the NHS has been fantastically strong. And that sounds slightly counterintuitive to some people, but actually the work that's gone on providers has been fairly exceptional. I had a meeting with the Mayo Clinic very recently, and it was their view that the NHS is the best value healthcare system in the world. And I think we need to hang on to that there's lots of room for improvement, but actually the NHS is a fantastic lean and efficient system. And that sort of leads me into Anita Charlesworth's presentation, because we have a very lean system. And if we look forward, and her figures are broadly speaking, I recognise and agree with those figures, that the status quo is simply not possible. It is not possible for the current system to live within the figures that Anita showed in her sort of 4 or 5 year forward projection. So the status quo has got to change. And I just leave you really with just two thoughts of how I think we can do that. If you look, I joined the NHS back in 2002, so I've been in it for roughly sort of 15 odd years. And over that time, we have externalized the pressures for improvement. I mean, in the early days, it was all about targets. We then went to choice and competition. And more recently, we have put much more reliance in regulation. And that's not to say that all those three have not had an impact. But actually, if we're going to make a real quantum leap in improvement, then we've got to re-engage, particularly with our clinicians, but across our entire, all the staff in the NHS. And I have been really struck with the work that's come out of the Carter programme, led by Tim Evans and Tim Briggs, that there is a real thirst, I think, for greater clinical engagement in reducing the variation, the unwarranted variation around clinical outcomes and clinical practice. And whether we attack variation through right care at a population health level, or whether we attack it through the performance, through the Lord Carter's report, or whether we attack it through clinical variation, through the getting it right first time methodology that's been developed by Tim Briggs. That is where I think there is real scope. We can re-energise that intrinsic motivation of the staff who work for the NHS. And the second area I just saw for myself this morning is the accountable care organisation, or the ICO approach. And I saw it at Salford this morning, where you have an organisation now which does comprise acute care, social care, community care, mental health care, and primary care. It does enable a much more integrated approach to delivering health and social care, and it will drive down costs. So I think it's, and the other model that I have been very struck with, again, is the development of chains. If we can get greater standardization and greater economies through developing chains. Now, both those structures do require individual organizations to give up a level of sovereignty or independence for the greater good. And we have to build governance models akin to what they've developed in Manchester, where they have probably further advanced than anywhere in England, where there is a real governance structure around these new organisations. So I think if we can re-engage the workforce, particularly the clinical workforce, if we are big enough to give up some of our sovereignty in developing these new models of care, then taking those two together, we have a chance, and it will still be very tough, of delivering an NHS over the next 5 years within the financial constraints that were described by Anita.
Thank you very much indeed. We will take questions from the floor, so if you do have a question, please put your hand up high and clear, and we will get somebody with a bat and a microphone. I can see one over there already. But just while we sort all that out, Anita Charlesworth, I was really struck by your slides, and we are where we are, is what they seem to say to us. But where might we be? I mean, are NHS funds taking into account things that do change, like population growth, for example? One of the things that is a salutary thought, I think, for all of us is obviously the health service is actually seeing its funding grow overall compared to other public services that are seeing their funding cut. But funding for the NHS is growing at about a quarter of the rate that it's grown, over its history. So, and really, I think the thing that makes that hard is not just the scale of that change, but it is now the duration, yeah? So you can do things for a year or two, and if you see at the beginning of the decade, you can do things for a year or two. But if you're looking at a decade, you have to approach things in a different way. And I think one of the things that has been difficult for us is that in the early stages, I think we had too much of a focus on the short term and the one-off, and saw it as a little bit of just an interruption in the history of the NHS, and if you like, normal service would be resumed. Whereas actually, to some extent, austerity is the new normal. And it's working out how now to focus on the underlying fundamentals. You always wish you could have gone back and done that earlier, but given that you didn't, it only gets worse the longer you delay. So, it would have been nice to have been here, thinking about, having NHS improvement, having the focus on some of these issues 5 years ago, but it'll only be worse if we would delay another couple of years. Well, let's turn to Ian over this, because you do get it in the neck, rather, don't you, for not thinking about this earlier. The recruitment could have been better earlier. We could have foreseen that we would have been short of the people that we desperately need, hence the reliance on agency staff and hence all the bad stuff that comes with that. What do you say to that? So
if we take the nursing workforce, the nurses that have graduated this year, the commissions for those were placed in 2012. And in 2012, the employers in the NHS were predicting a significant reduction on the number of nurses that they wish to employ, because if you remember at that time, we were very much focused in building up community care, the impact that technology was going to have, transfer of care from hospitals into the community. So the actual workforce plans that were coming in were significantly falling in terms of the demand. What happened at that time was the nursing commissions were reduced. Now, with hindsight, that proved to be the wrong decision. Because we didn't see the same level of transfer of resource from acute to community, but also we saw the big focus on quality post-mid staffs. And some of you may remember a slide that I showed last year, that over the last 10 years, the number of consultants in employment in the NHS has gone up by 50%. The number of nurses in employment in the NHS has gone up by less than 10%. And that mismatch has been part of the problem we had with quality.
Yeah, and is it true to say the HE budget has been cut?
The HE budget has been fixed, so it hasn't been cut, it hasn't been increased, but what's happened is that a decision has been made to transfer the funding of nurses and allied health professions to the student loan company to try and encourage an expansion rather than contain the number in the fixed budget that we had.
Let me throw that immediately to Lord Pryor, because everybody is identifying staffing is everything. Workforce is everything. It's the only way that we're going to fix these problems, and how you roster them and how you use them most effectively, that comes into play as a second tier. But if you have a frozen stroke real-time cut as we go on in time to his budget, you have things like the bursary for nurses cut as a reality. Are you not expecting an awful lot of people without arming them for what they actually have to face in the future?
Well, the cut in the bursaries for nurses should actually result in more nurses by replacing bursaries with student loans. So, I mean, that should take the cap off the number of nurses. So that will actually enable the nursing workforce to grow. But I think it is one of the great, conundrums of healthcare is that we face short-term problems, but actually all the solutions are long-term. And actually, to the question, when is the time to start developing these new models of care, the answer has to have been 10 or 15 years ago. In 2000, the NHS produced a plan, and it was talking about all these things. I expect Simon Stevens wrote that plan in 2000. And the truth is that everything we've done since 2000 has been to reinforce the status quo. We have seen more and more of the available resource go into acute care, whether it was driven there by the tariff or by waiting time targets or the like. And so you get what you incent for in this life, and we have incentivized a massive growth in the acute sector at the expense of mental health and primary care, and that is what we've got to change very quickly.
So one of the things that came up in that first conversation, we had the voice from the LGA saying actually we need 5 years or 6 years to get to where we need to go, and they are a signatory to this 2020 deadline. And I put to her, I said, so are you regarding this 2020 deadline for efficiency savings as an aspiration rather than a hot deadline? And I seem to get from her that it was more of an aspirational thing, a necessary aspirational thing. I'm guessing the government would have another take on that.
Yeah, no, I don't think the £15 billion is beyond achieving it. Actually, if I look at all around the purchasing, pharmaceutical optimization, medicines optimization, and our property, the way we run our property, I don't think the £15 billion is an absurd number at all. I think that broadly speaking, I do think that's achievable. What I don't think is achievable is that we can completely move from the current model of care to the new models of care over that time, because in creating these new models of care, you have to build relationships and partnerships and trust across organizations that have been fighting each other for resources for a generation. Now, it's happening in Northumbria, it's happening in Salford, it's happening in certain parts around the country. In America, it's taken them, and they go very fast in America, 20% of the population in America is now covered by accountable care organizations, and from almost a standing start about 6 years ago. If we get 20% or 25% of the population covered by accountable care organisations over the next 5 years, we'll have moved pretty quickly.
Okay, and we're going to take questions. Very, very briefly, Bob Wachter, who was speaking earlier, said you have to get this IT brain needs to be baked in, and a bake takes time. And what we're hearing is from Anita, we don't have that much time. How realistic is it to expect people who are not used to this way of working to suddenly get their heads around using IT in the most efficient way?
I think you have to offer something for them. It's got to make their life better. And if it's being imposed on them to help people higher up but not helping themselves, it's not going to work. So you absolutely have to bring the workforce along with you. And that's something that we're trying to do with our tools. I gave some examples there. But yeah, you're absolutely right. If it doesn't do something for them and it just makes their life harder, it's not going to happen. But
OK, let's take some questions. We have got somebody here, number 2. Yes.
Sam Ebrington, Chair of Tower Hamlets CCG. Mainly a question for Ian, but touching on what David talked about effectively the lack of GPs produced by medical schools and universities. There are 50 professors of general practice in this country, thousands in the acute sector. Only 13% of training of medical students is done in general practice, and yet your team tell us that it's a third the cost of training a medical student in general practice. And when you look at the output of medical schools, it varies between 7 and 30%, depending on the GPs they're producing. Isn't it about time we held the universities and the medical schools to account and adjusted the resources they are given on the basis of the workforce they deliver for the NHS?
OK, thank you.
Thanks. So I think you raise a very valid point there, and we talk about parity of esteem between mental health and physical health. We also need to talk about parity of esteem between primary care and secondary/tertiary care. We need approximately 50% of medical school entrants in this country to become GPs. That's the workforce planning numbers going forward that we need. We are not at those levels yet. We are seeing broadly consistent numbers of people wish to enter GP training every year, and that figure is about 2,700. We're expecting to see that number increase this year, but we are still somewhere in the region of 300-400 minimum away from the numbers that we wish to see. We know that there is a correlation between where people visit as part of their training, where they study as part of their training, and the decisions they make around where they want to work. But one of the issues that we still have to address in primary care is the perception in medical schools that it's not really a place that they want their medical students to go. And only 2 or 3 years ago, we had an example of a flippant comment being made to a group of medical students that basically said, you're here to work hard, you're here to have a good time, but if you don't work hard, you'll all end up as GPs. Now, we have just got to accept that that cannot happen. That is not the environment. That we need highly skilled, highly trained professionals across the spectrum, not just in any one sector.
We are I'm just doing a plea for more time from the powers that be, because I know there are more questions. I'll take one more until they come on and put an electric cattle prod in my back. But number 3, let's go for that.
Yeah, thank you. It's Tim Cotton, GP in West Hampshire. The financial report left me feeling about as gloomy as the weather outside. And my point is that we get these inspirational documents like GP Forward View, STP stuff, and then we wait and wait and wait, and then we find out this is actually the money is the money. And it's about the messaging, really. Are we getting the messaging right in the NHS?
OK, let's give that to Lord Pryor.
Well, I think Anita's slides, tell the truth. It is going to be very, very tight, and we are already a very lean system by any international comparison. And it's not because the government particularly want it to be tight, it's because we have a £70 billion current account deficit. Now, it is tight, and, the benefit of that is it is going to force change, which I think most of us we may not agree about the amount of money we're spending, but actually to get change in the NHS, you have to keep it very tight. And if we are going to change these models of care, which I think will actually, if we are successful in changing the way we deliver health and social care, it will, I think, very much change the status of GPs, because actually I think they're going to be much more heavily involved in these new models of care than they are at the moment. But I don't think there's any getting. I'm not going to kid you that things are not going to be very tight financially over the next 5 years. They are inevitably going to be.
Let's take one more question. They're very kindly indulging me. I'll get into trouble later, but you're worth it. Number 1, let's go for you.
Thank you. Tom Cowell, Chief Executive of Hertfordshire Partnership Trust. First thing, just a comment on the bursaries. There's very few people in the nursing profession and outside that agree with your view that we think that we'll get more people. So I think we just need to call that, and we need to be clear about it. I think it's going to give us a problem. Second, the point I want to make is, Ian, you rightly put a lot of the onus back on the providers for the working environment, keeping the staff we've got. And you're right. We need to do all the work around productivity, technology. But can I ask you specifically what you think Health Education England is going to do? Because I'm leading a programme in Beds and Hearts about supply, and we pick all of those issues up. But there is a significant issue about long-term training and getting people in through. So this year we didn't increase the nursing numbers like we thought we should because of the money issue. So give us a sense of what you think specifically Health Education England will do to help us with what is, I think, the single biggest challenge the NHS faces is workforce.
Okay, so I think we can help at several levels. One of the key ways in which we can help is by identifying best practice elsewhere and bringing it to other parts of the country through our local teams, because we do see some fantastic practice, and I'm absolutely convinced if we could only spread that and spread that quickly, then a significant part of this solution is addressed. I think we can help with new roles, so training physicians associates, or indeed the new nursing associate role that we've been talking about, that the first 1,000 will start training this year, a role that will sit between healthcare support worker and degree level registered nurse. I believe that that will help, and that's a role that is being asked for in all sectors of the NHS. And I think we can also help by making sure that the workforce that are coming through are fit for work, fit for employment. And we are hearing increasingly that in certain roles, people are actually coming into those roles newly qualified, but then actually we have to train them to be able to do the job that the NHS needs. So if we can understand what those issues are from you, work with the HEIs and other organisations to change the curricula to make sure that people are work ready when they graduate, I think that will help with the overall efficiency and productivity.
Thank you all very much indeed. Stay where you are, but first of all, let us thank our panel. Anita Charlesworth, Simon Courage, Lord Prior and Professor Ian Cumming. Thank you all very much indeed. Thank you.